Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Well, it's 9 o'clock, so I guess we can get started. I wanted to start off by talking about a couple of things that are in the post, which I thought were kind of remarkable in the sense that one of the top headlines was that there's an interventional program that helps tackle racism, cancer cure. We all know that cancer in African Americans seems to kill us more often than it does other ethnic groups. And there have been a number of programs. What was interesting about this interesting article on intervention program helps tackle racism in cancer care is that they have actually put into practice what Harold Freeman talked about when he got the Alaska Prize in 2000, which is that much of the reason why African Americans die from cancer more than any other group is because of access to care. And this is when this is addressed, as he started addressing in 2000. Then many of the mortality, the drastically low mortality rates, or high mortality rates rather, go away because the social determinants of health play a major role in why Blacks die from breast cancer more than any other group, especially when we're talking about women. But it was interesting because the article talks about many of the programs that are now addressing the social determinants of health. And it actually never even mentioned his pioneering work back in 2000. And so I thought that was interesting, but then that is not a rare case. Sometimes the original work is kind of forgotten about. But it's good that people are taking advantage of recognition that the social determinants of health play a major role in some of the reasons why Blacks die from breast cancer and other illnesses. And I thought that it's a great article because it does focus on the specific intervention. It talks about this lady who had breast cancer and needed treatment, but treatment was 90 minutes away. And she couldn't get anybody to help her get to where she needed to go to get the treatment. So she refused to get the treatment. But she found a cancer center that would come and pick her up and take her to the treatment place and bring her back home. And as a consequence, she got the radiation treatment she needed, and she's now 2 years after being cancer-free. It's a good example of how access to care plays such a major role in healthcare, and often we forget about it. It's just as we noticed with the coronavirus, how many times the people couldn't get access to it because of reasons that were really related to the social determinants of health. And the 5 social determinants of health relate to poverty, environment, and things like transportation, simple things that make a difference between life and death. And I thought it was a great article to point that out, even though it did not recognize that this intervention was really begun in 2000. And actually, Harold Freeman who was one of my chief residents, actually won the Lasker Prize, which is the American equivalent of the Nobel Prize. The difference is staggering in that you get $1 million for the Nobel Prize and 100,000 for the Lasker. But anyway, that was one of the excellent articles that the Washington Post talked about. The second one was an equally fascinating article about the people who actually developed RNA and pointed out how important it was and how that has now resulted in the development of the vaccines that are responsible for drastically reducing the number of deaths in the United States and across the globe. And it talks about how Drew Weissman and Cataline Carrico nearly 30 years ago began their work on RNA and how that now, 3 decades later, their work is being appreciated. And it's going to be interesting to see. They got the Lasker Prize for that work. It'd be interesting to see if they also get the Nobel Prize. But this was the basic fundamental work that demonstrated that RNA could be used to develop vaccines. And while much of the focus has been on those people who actually created the vaccine, which they did not, still it all goes back to the foundational pioneering work of these investigators who identified RNA and stabilized the RNA so that it could be used to develop these vaccines. So, any thoughts about those comments, or do you have any thoughts about it?
What is RNA?
Okay, DNA is the primary source of all genetic activity. It's in the nucleus. RNA is DNA, desoxyribonucleic acid, found in the nucleus. It makes everything happen. And RNA is also in the nucleus. It also does that, and it's not quite as stable as DNA. So a lot of attention. People won the Nobel Prize for identifying DNA as being the prime protein for signaling cells to work. RNA signals cells to develop immunity. And so that makes it a little different. So the whole immune system is based upon the two, the DNA and RNA. But much more attention was given to DNA because it was the first one developed, and the RNA was less stable. But the ribonucleic acid, RNA, is what has been used for the new vaccine, the coronavirus vaccine, and likely will be used for the development of many other vaccines now that we've actually taken advantage of using it and seeing how effective it is.
Thank you.
Does that answer that question?
Yes. Yes. Thank you.
Yeah. Okay. Any other comments on why it takes so long for some people to work to be recognized? That's, one of the things that I've learned along the line is that one of the biggest obstacles to success is when people need to get credit. And so one of the best things you can do if you want to work with people is not to worry about credit at all. Just do the job and do the best thing you can. And the way I looked at it as I was working with the Transplant Center was that do it as unto the Lord, and don't worry about getting credit. Just do it as unto the Lord, and everything else will take care of itself. And who needs credit anyway? You just want to do the best you can and make things happen positively. And if you want to stifle things, worry about who gets credit for it. And but I find that many people worry about who gets credit. I have never worried about who gets credit. I just worried about doing it as unto the Lord, and let things fall from there. Walking back and going the rest of the way. Anyway, that
I can imagine that racism plays a part in that as well. In other words, sometimes Black people are hot on discovering something, and it's snatched away from them by white people.
well, racism is a part of everything in this country, and it probably is part of everything in the world. I mean, you know, we talk about racism in America, but what racism is a system in which one ethnic group is thought to be superior to another, and that's in every part of this globe. It's called differently here in the United States because they've taken advantage of Black people and made them slaves and taken advantage of what they had. But it's not unique to America. It's everywhere in the world that racism is evident. It's just called different things. And yes, you're right. Not infrequently, things that Black people started taken by others, and then they crossed the finish line with it. But the foundational work is what is important. And you may argue that the giving away of credit is unfair and wrong, and unethical, and that may be true. But still, the focus on getting credit is problematic in the long run. In the short run, may not be a problem. And as you work in different groups, you find that there are people who are obsessed with taking credit, and that can be a deterrent to progress, as racism often is. Okay, if there are no other comments, John, you can start the slide. So there's another article on the why you're starting it on salt. We talked about salt before and sugar, and the two poisons that kill us. And it talks about decreasing that. Now, this is an article I thought was interesting for us to talk about because most people don't think too much about the impact of death on physicians. And as I look at, I'm in the field of transplant where when I started off in transplant, the success rate was only 50%, which means that half the people you work on are going to die. And so you would have to wonder, what kind of impact does that have on physicians? How do you cope? How do you manage when half the people you work on die? And how do you manage to survive and continue to do that? How do you handle the stress, the guilt, and the actual fact that you failed you feel that you failed the patient, and that what you've done is not good enough. And you see here that 61% of the physicians that the most memorable patient death they witnessed hurt them forever. Well, I remember, first place, one of the things that you have to recognize is that doctors are human beings.
Right.
And doctors make mistakes. And some of the mistakes they make may help people, some may kill people. And so this then you have to recognize is going to have a tremendous impact. I remember the deaths of my patients from when I was a resident, which is more than 50 years ago. And I remember virtually all of the failures that I participated in. And of course, one thing that helps balance the scale is your successes and the people who do well. But that's why it's always been interesting to me to understand why any physician would be arrogant, because we see so many people die in spite of us or because of us, and we see people who survive in spite of or because of us. And so we ought to be the most humble of all people. So the question is, how do you help the physician who actually grieves when the patient is lost? And most times, the doctor does not manifest the grief that he has because he's lost the patient. And I remember Pearline Freeman talking about her reaction when her doctor told her that she had renal disease, and how she actually had to comfort her doctor, so that we grieve, and it is not, it's human to grieve, and so it should be expected that we grieve, and then is it okay for doctors to cry when they lose patients? Of course, because we're human, and so the more humanistic we are, and the more humanistic we manifest ourselves, the better off it is for patients. And so early on, there were no such thing as death debriefing sessions in which the physician was helped to cope with death. You just dealt with it and moved on. And now we recognize that the physician is in great need of support when the patient dies. And what was the most comforting to me, and what I did to train my residents to help them, was to let them understand that life and death is not really in your hands, that there's a greater power that determines life and death. But your responsibility as a physician is to do the very best that you can. And when you've done the very best that you can, then you can take solace in that fact. And so the reason I had a tough reputation is because I demanded that you do the very best that you can. And mediocrity was not accepted because patients' lives occur. And so when you've done the very best you can and you recognize that life and death is not in your hands, then then you can survive. And that to me is the greatest opportunity to recognize that you have the right to grieve when you've done the very best you can. If you're not doing your best, I'm not supportive of you. But anyway, that's just an inside look at the things that go on in the physician's mind as they deal with success and failure. In many other fields, success and failure does not take you to life and death. But when you're a healthcare provider, life and death are the things that you have to deal with. And you have to learn to deal with deaths the same way you deal with successes, and recognize that the power that controls success and death are the same. And what you have to do is to take advantage of the gifts that God has given you and use them to the best of your ability. When you've done that, then your grieving process is much softer and kinder. Now they talk about, go ahead, Darryl.
I have a question. In your experience, how does the physician group compare to the general population when it comes to having healthy hobbies? Do doctors tend to have as much healthy hobbies as everybody else? Less, more? What's your experience?
My experience is that, and I've dealt more with Black doctors than others, is that we have a lot of hobbies. We grew up, and medicine was not the first thing we worked at. And so most of us have other hobbies. So we have fun doing other things. So that helps us as well. And I think the point of broadening your horizons becomes important, because if everything you do hinges on what happens with your role as a doctor, then that's extremely difficult. So diversification and having hobbies and other things that you do, just like, for example, you do so many things, Darryl, that diversity is very helpful. And I think, yes, answer your question, especially the doctors, we have many hobbies. What we sometimes don't do is when we get so and hooked up with medicine that we sometimes let those hobbies go, and that is dangerous because you're not going to be a doctor all your life. Most people aren't. Most people are going to retire, so you have to have something to fall back to, and therefore the hobbies become the things that carry you after you've stopped your practice of medicine.
Dr. Callender, we had this before with Maya introducing to us and telling about the grieving process. How do we help others, and particularly in our church, when they tell you don't grieve, don't cry, and etc. It's going to be okay, and it's a glorious day that this person has died. Is there anything we can do as individuals or as a group to help everyone to learn how to grieve? Because it seems like in our society, we're shutting down everybody if they want to grieve.
I agree with you that grieving is a process that you must go through, and it is okay to grieve. And I think the essence of the message that you're giving is that yes, in death you're born again, and there is a second life, and there's maybe a second death. But it's okay to grieve and to miss people, and crying is good, healthy, and encourage it. So I don't discourage anybody from grieving or from crying, and neither do I discourage them from celebrating the life of the person, because I think the celebration of the life is an important part of the grieving process. So I don't destroy the concept that you should celebrate, but I say that you should do both. You should celebrate their lives, and also you're going to grieve for them because you miss them. That's what you're saying. You know, when we talk about the hereafter, one thing that we never talk about is the fact that our physical bodies are gone. And so we're talking about spiritual, new heaven, new earth, new spiritual bodies. And so God is a spirit. And when you become an angel, which is the next step, we're not going to be able to recognize you because you're not going to have a body. So we tend not to even address that. I've never heard that even addressed in any funeral. And they talk about we'll see him, her, in the hereafter. Yeah, you will see the spirit, but you won't see the body because the body's gone. So how are you going to recognize your loved one? And that's never discussed. But yes, you should celebrate the life of a person. To me, that's an important part of the grieving process. But you should also recognize that, let's face it, you're not going to see him in that form ever again. That is harmful and hurtful to many people, but that's the truth. Any thoughts about that? I don't know if you have ever thought about it as you hear people say, we will see them in the hereafter. Yeah, but they won't have any bodies, remember. This is different issue.
I agree that preachers often say, you know, when you get there, you mother be there waiting and father be, but, you know.
Yeah.
I've often wondered about that myself. That, you know, the bodies are gone, so how are we gonna know who it is? But yeah.
I've never heard anybody talk
I've
about
never heard it either.
But it's
that part of it.
And you know, and John says, was it John, the second chapter, I think, he talks about that when we get to him, we see him as he is, because he's a spirit. But nobody talks about how we're going to recognize each other, how we're going to know that they're spirits, and because we, you know, it also talks in Psalms about we're a little lower than the angels, and so the step up for us would be to be angels. So and angels don't have bodies, so how are we going to do that? Anyway, it's food for thought to think about as we all are going to die, then that means we will all become spirits, because our bodies will deteriorate, and that's why many people go ahead and get them, go and get what do you call them?
Cremated.
Cremated, right? Because they recognize that in the hereafter, the body's not going to be here. And that's why the active organ donation is a positive thing, because your organs will be used to keep somebody else alive while you're gone. Otherwise, the body goes and deteriorates completely, and it's of no merit.
One more thing, Dr. Callender. I was telling someone, they were talking about an inexpensive way of leaving here. And I was just wondering, is that talked about much when you give your body to medical science, and they bury you and you don't have to pay anything? Is that true?
Yes. Yes, and that's, that's something that we tend not to talk too much about. I've been to many ceremonies in which the families who have donated their bodies are honored, and they appreciate the fact that their bodies have been used to teach medical students and to make things better. And then after that, the bodies are taken away. But yeah, but what's surprising to me that there was so many people of our ethnicity who actually did that.
Dr. Callender, I remember as a teacher, I guess it's about maybe 15 years ago or so, John Tatum probably remembers this. The teachers all had to get together for these training sessions about grieving. And, it's one of those things that really came to the front much later than those sessions. So whoever thought about that was really thinking ahead, because a lot of our students, teaching in the public schools, I had a student in class on Friday, and he was acting out. I put him out, and Friday night he got shot on the street corner.
Wow.
So we deal with loss as teachers, and inner city teachers a lot more. And so learning how to grieve is something that that they had sessions on for teachers. Having to deal with this. In our neighborhoods, the gunshots going off and drive-bys and all this stuff that's happening. That we hear about in the news, it's pretty scary. So, having that support and having those techniques for, dealing with loss, it helped me when my mom and my dad and my son passed away as well, because I was able to like focus on the positive, and thanks.
Well,
Okay,
I think we learn too in life, there's no set way to grieve. It's an individual thing. When we were doing the act, for instance, grief was a big part of that. What is grief? And this is me personally speaking, I still don't really know what grief is. People tell me, I don't think you've grieved yet. It's not a step by step. It's not a 1, 2, 3 thing. We grieve individually. You grieve not for a day, not for a month. I don't think it's a limit on it, but I don't know how you can define it as being one thing. You have to cry to grieve. What does that mean? If you're happy, you're not grieving. I think we all handle emotions differently. You were talking earlier about doctors, physicians, and I often wonder, how do you do it? You have to show compassion to deal with a patient, and that patient needs to feel that compassion to respond to what you're telling them. And then when you lose that patient, it's difficult for the family, but I think it's even more traumatic for the doctor. Emotions are just all over the place at a time like that. Maybe I'm not explaining it well, but grief is a big part of life, actually. And at times, I guess we all will go through some form of grief, but they can't teach you to grieve. It could be years down the line and you'll eventually say, okay, I've put that aside. I'm finally at peace. Obviously, I'm rambling, but it's an emotional thing for me. And I just don't know yet what that term grieve really means. I know how it is to be attached to an individual as a physician, being attached to a family member. I know Dr. Callender, you were very, very close to my family during my husband. I know the surgeon who took care of David. It was 30 days with him. And the last week, one of the nurses said, oh, I think he did something wrong. And I said, oh my goodness, what's that? And she said, he fell in love with you guys. We were the ones who, after the 13th of March, the only ones that were able to stay in GW Hospital. We were the only non-medical staff, my son and I, walking the hospital. And I noticed that last week, he showed more compassion than he did the week prior. Then I was no longer Mrs. Stevenson, I was Janice. And then the last days, when you mentioned about Pearline and how she had to comfort her doctor, that was the position that I was in. Maybe we can do this, maybe we can do that. And finally, I had to tell him, it's okay, which was a difficult thing to do, but it's an emotional time. You doctors get involved in hundreds of people. But is that a grieving process? It's difficult to say, I lost a patient, I love that patient and go forward, but it's something that you have to do. So as an individual, when we all share loss of a family member, I've learned it's not for a day or a month or a year. You show some form of grief throughout your life.
Okay, this
Well
is
expressed, very well
sure.
expressed.
This is just take a few seconds. Several indications in Scripture that we will maintain our identity in heaven and thus be recognizable to our loved ones and they to us. For example, Jesus makes it a point in Matthew 22nd chapter that Abraham, Isaac, and Jacob were alive and existing as individuals by those names. In Matthew, Peter, James, and John recognize Moses and Elijah. In Thessalonians, Paul expected to recognize in heaven the Thessalonian Christians whom he had ministered to on earth. In addition, Paul says, for now we see in a mirror dimly, but then face to face. Now I know in part, and I shall know just as I am known. That last phrase, I shall know just as I am also known, would indicate that we shall know others as well as be known by others.
Well, I think we've heard some interesting descriptions of grief, and I think in the way in which you describe grief, it's clear what it is, and it's clear that it is, as you expressed, Janice expressed it well in terms of what grief is, and also expressed the fact that we know when we're born to die, and so grief is always with us, and so accepting that is probably one of the most important parts of the grieving process, and that those you love are going to die, and you're going to die, and it's interesting how we talk about some of the techniques involved and helpful in yoga, mindfulness, exercise, meditation of all sorts, and healthy hobby, which take your minds sometimes off of the grieving process. Sometimes that helps a lot. But I think all of the ways you've described grieving is what it is. And as you said, there's no timetable for grief. It begins and ends when at the beginning of your life, and ends when you die, probably. but nobody can tell you how long you should breathe or how you should breathe. It's a very individual thing. Okay, is there any more? Yeah, okay. Any other comments about that from anyone before we go into the vaccines, back to the real deal? Okay, I think this is an article that talks about the different vaccines, and we know now, as we talked about the RNA being a relatively new methodology compared to what we had in the past, even though it's not new, as from our discussion you can realize, working on it for 30 years, but actually just incorporating it into a vaccine recently, right? And the flu is interesting because every year we have a new strain of the flu, of the vaccine, flu vaccine, and many have wondered, is that going to be the same thing with COVID? And I guess we don't really know. But we know with the flu every year, it's a different version of, with different strains of the virus being incorporated into the vaccine. And how long is the flu vaccine protective? That's another thing that may vary with age. And that's why people over 65 get a double dose of the vaccine for the flu and for the different vaccines. One of the things that you kind of recognize if you look at the success of the vaccine is that many of the vaccines are successful up to about 50 to 60%. Not too many of them are in the 90 to 100% range. And so one of the most important things about these vaccines is they strengthen your immune system so you can fight off the infection. So that's what immunity is all about, is enabling your immune system to fight off infections. Any questions or comments about that? Because how many of you already gotten your flu vaccines?
Got mine.
Mine. Yes.
I got my booster shot.
Yes. I got both, the vaccine and the booster.
I got
Yeah.
Not at the same time, though.
Got boosters yesterday. I'm getting my flu shot tomorrow.
Yeah, I'm getting my flu shot today. So
I'm getting both today.
And I
okay.
also got my shingle shot.
Oh, wonderful. Good.
Well, the first one, I get another one in December.
Okay.
How often do you have to get the shingle shot? Is it once a year or?
Yeah, two.
No. After you get the single shot, it should last for about 5 years.
Okay.
Something like that.
I think it's in two stages though, Doc, right?
Yes,
Yes.
that's correct. Yeah. Mhm.
Does anybody know if a shingle shot is paid for with Medicare?
They were going to charge me last year.
And I don't know. I don't know for sure, but it should be. I mean, it's.
I got mine last year and I have not received a bill. I don't know if it was paid by Medicare or if Blue Cross Blue Shield is my secondary, whether or not they kicked in, but I have not received a bill for it.
I never received a bill for it either. So.
Yeah, my shingle.
But then I'm still working, so it's not Medicare.
Yeah, my shingles vaccine is about 10 years ago. So I guess I'll
It's
get it
done.
because I've had shingles twice and I don't want it again. It's the worst thing in the world.
Yeah. It's time to get another shot after 10 years. Yeah.
But the calendar, is that the future of mankind, fighting off viruses and mutation of viruses?
What do you mean future? Today and tomorrow.
Present.
Today and tomorrow, yes. Yes, yes. You know, we talk about trying to be immortal. Well, you know, that's a tough deal. Do you really want to live for 200 years?
No.
As healthy as I am today, I'll take 200 years in a minute.
Yeah, well, but staying healthy is as Darryl said, is the issue, because it's the quality of life that you want to have. And as long as you can live to be 200 and stay like you are today, it's okay. But it involves boosting up your immune system, because the tendency for your immune system is to decrease over time, and that's what the vaccines help you with.
My question really has to do with, you know, how many vaccines are we going to have to take, you know, like 20 years from now and 30 years from now? You know, how many you go to CVS and get in line because you got to take about 10, 15 different vaccines. Is that where we're headed?
Well, it's likely that some of them will be pills. Just like the new COVID vaccine, that's going to be a pill. In the future, probably will be pills. But I'm sure you will have to have some way to boost up your immune system as you age. What is distressing me a little bit is only 27% of people in low and middle income countries have access to the vaccine. That's a little distressing. And we talk about equity. It is true that these people who make the vaccines are getting rich.
Dr. Did you hear, I think it was like the World Health Organization and like the people over in Africa, they were asking to buy the vaccine, but you know, I guess dealing with the thing of, transports and stuff, that, stuff not going out. Because he was saying, we don't want you to give us anything. You know, we accept donations, but they wanted to buy so they can vaccinate the people in Africa.
Yeah, well, it's interesting because everybody who gets the vaccine, they pay for it. And if they pay for it and then they give it away, that's one thing. But that's an interesting statement, that they want to pay for it like everybody else. And this talks about the what's going on behind the scenes. See, in Africa, 95% of people are yet to be fully vaccinated. And so we've got a long way to go. Because it's a global phenomenon. It's not a one country. All of the world is affected by these diseases, especially COVID. And to the extent to which we allow a segment of the world to not be vaccinated, that's the extent to which you have these
variants
that can turn out to be lethal. So that we need to have as many people vaccinated in the world as possible.
All right, let's go.
Is there any other country besides America that's fighting the vaccination? Or we're the only country?
No. Now the only question is to what extent, because I think every country has some hesitancy, and they've got some religions or some different communities that don't take the vaccine. So the question is, what percentage are taking it in the United States and what percentage in other countries? I haven't seen all of the numbers yet, but it'd be interesting to see. I think a lot of people aren't taking it because they can't get it, and so that makes it difficult. Now, if you just look at the developed countries, then you might be able to get an answer. Now, this is, remember last week we talked for the first time about xenotransplantation, which is what we talk when you talk about transplants between different species. And this transplant was done last month. This is not new. Now, keep in mind that we've been doing xenotransplant since the 1960s. But when HIV came around, which is a disease that came from the primate model, the monkeys, then because of that, all efforts at xenotransplantation or transplantation between species stopped. Now, one of the reasons it stopped is because most of the xenotransplants that were done were rejected. And remember, there's a difference between a tissue transplantation that they use for heart valves and from an organ transplantation. Because the tissue is not, it's alive in a way, but it's not functioning. It's just a mechanical thing. Whereas the organ has got to function. And one of the things that you want to do is to make sure that you don't get an infection from the organ that you get, so that you have to have a model in which is safe, doesn't give you a disease, and also doesn't possess the antigens. Antigen is the part of the organ that causes the immune system to try to destroy it. And we knew that with any species, there's an alpha galactose epitope that causes hyperacute rejection, which means that when you transplant, within minutes to hours, the organ may be rejected. We call it hyperacute rejection. So what they did, they had pigs that they used special techniques to take away these sugars that trigger rejection. And so this alpha gal is sugar. And these pigs don't have this, and therefore they can be transplanted without the fear of hyperacute rejection, which doesn't mean that in the long run they won't have rejection, but it does mean that they won't have the early hyperacute rejection that has been the problem for most xenotransplants. And so the question is, now that we've eliminated that obstacle, the next step is to make sure that we can do it in a way that allows the organ to stay without being rejected, which means you have to have immunosuppressive medication. And the question is how much immunosuppressive medication is necessary for the xenotransplant compared to the allotransplant, which is the term we use for transplants between members of the same species.
So I had a question about, are you saying that they genetically modify the pig first?
Yes.
Before the transplant?
Yes.
Oh, okay.
That's what made the experiment, which it is, work, because they genetically modified and made the pigs not have the sugar that causes the hyperacute rejection. And so there's only 100 of them that have been created like this. So the question is, will this work so that we can make 1,000 pigs? Now, as you know, we have more than 100,000 people in transplant waiting list, and we only do about 40,000 transplants a year. So you got 60,000 people who are waiting, and because of this long wait, 20 people die every single day because of the shortage of donors. And so this then, the question is, would you rather have a pig kidney which would keep you alive, or would you rather just die? And so the question is going to be not, now that we have the technology, should we have xenotransplants? Because that's the ethical issue that will come up shortly. Is it okay to have a pig kidney or a pig heart?
Yeah.
How many of you would think about accepting a pig kidney or heart if it would keep you alive?
Amen.
I would.
Yeah, my husband said he would. Amen. Life or death, I think I would too.
And that is the ethical question that is going to be the question of the day. Now that we know that we can, should we? And what is going to be the religious and ethical response? When we were doing xenotransplant, there were many groups that opposed it. And if this becomes successful, that same issue will occur.
I'm thinking that animal groups probably might be one of the ones being,
Yeah.
Because the pig, after you modify them and you use them for a transplant, they die, correct?
It depends. It depends how many. If you take out one kidney, they wouldn't die. But if you take out 2 kidneys, they would. If you take out the heart, they will. Right. Yeah.
So I'm thinking that the animal groups would be opposed.
Oh, they are. As a matter of fact, they always have. As when we were doing xenotransplants, they would always come out and protest. But then, do they protest when we eat the pigs?
No.
Well,
when they go to slaughter and they have
yeah, I mean,
all that.
Yeah. So anyway, but you're right. They're going to be one of the groups, and then you're going to have groups, religious groups that will, especially the pig. Is an animal that is thought to be filthy. So.
Dr. Callender, I can remember years ago at one of the early transplant meetings in the late 90s, and you brought up that same question. Would you have a pig or an animal organ? And everybody's saying, oh, I don't think so. Now here it is now, a reality. It's a good possibility. If you want to live, yeah, you can get a pig kidney, heart, or whatever. But years ago was just so far-fetched. So we've come a long way.
Yeah. I remember
Yeah.
being on television with Dr. Death,
Kevorkian.
Talking about this subject, and they were. But it was interesting because when we breached the subject, about 95% of people in the audience would accept an animal if it was going to save their lives.
Mm-hmm.
You used to use the pig for dialysis.
Yeah. Mm-hmm.
They didn't protest then.
Oh, they protest any use of it. The animal rights people, they protest any use of it. But
I have a question about the size of the organs.
This pig, they use the pig because the size is very similar to human organs. That's why they chose the pig.
I know one of the things that my brother talked about shortly after he received his kidney transplant is that he started craving things that he had never liked or had a desire for. With having a pig kidney transplanted into a human, would there be things that they may inherit from that makeup, like you talked about the sugar? Would there be a less desire for sugar, maybe a more desire for sugar?
The only way we'll know that is when that happens. We'll have to wait and see. We have no idea.
More desire to eat bacon.
We have, we have
We
no
brought
idea.
that up, you brought that up last week, because obviously this is a transplant group. And I was wondering too, anyone who's had a transplant, do you see possibly where you crave things that you've never liked before, like a lot of sweets or alcohol? I don't know. Whatever might have been the characteristic of the owner of that organ you received. And transplant people that I've ever associated with, they couldn't tell any difference where they were prone to have any reactions to or cravings or lack of due to the organ that they received. So is that a standard thing, Dr. Callender?
Well, we don't know the answer to that question, and
Yeah.
most of the people who have been asked about it did not identify it.
Right.
But that doesn't mean that will be the same thing with the animals. I know with humans, we don't know the answer to that question, and it's going to. And we now have done so many transplants that it's a good question to continue to pose. But most of the people haven't expressed a difference. But there have been single patients who have said that they have noticed some differences.
Would a transplant change your blood type? I mean, if you were A or AB and now that you have someone else's organ, it's changed to another blood type. Is that known to happen?
It's interesting because I think we had Dr. Joel Stevens had one paper that we published that talked about that. That's rarely the situation with kidneys. As Darryl talked about last week, it is commonly the case with bone marrow, but not with kidneys
Or liver?
Not as we know with livers either.
Mm-hmm.
No, not with the organs, only the bone marrow.
Just speaking about that, Janice, you know, both of us know since our husbands went through liver transplants, I don't think, I never noticed any cravings that he might have, but you know, we as human beings, when we become pregnant, sometimes we have a craving for a certain thing just because of what our body is going through. And then after it's over with, it stops or it may continue. So that's just part of, I don't know, change in your body or something, and you attribute to that circumstance that you're in.
That's an interesting question that requires an interesting long-term study. We got enough transplants now, so anybody who wants to do that study can do it. But long before they even started that, people had concerns about getting a woman kidney if you're a man and a man kidney if you're a woman, and thinking that it might change that. But so far we haven't received any evidence that that's the case. But that study still needs to be done to answer the question. Now, this is an article that talks about the fact that anxiety, stress, about the pandemic and being closed in has caused people to drink more, and therefore alcoholic liver disease is once again becoming the #1 source for the need for transplantation. We felt that fatty, non-alcoholic, fatty liver disease would be #1, but it looks like people are drinking more than ever, and as a consequence, alcoholic hepatitis is taking over, and they think some of that is related to COVID and the stress and anxiety associated with COVID. When I first started out, alcoholic cirrhosis was the leading cause for liver transplantation. And over time, hepatitis C took over as the #1. But now that we have a treatment for hepatitis C, the thought was that non-alcoholic fatty liver disease would be the number one. But now it appears that the frequency of alcohol consumption risen, and therefore that's becoming the number one cause of liver damage that requires liver transplantation. I was a little surprised at that. What are your thoughts about it? I guess if any of us drank, we might have a better understanding of it. Because alcoholism is a disease like many others, and once you're addicted to alcohol, you're addicted. Any comments on this?
The alcohol the ones who have the liver disease from alcohol, do they get the same preference as other illnesses for transplants?
No.
Yeah.
As a matter of fact, it's an addiction.
Yeah.
So therefore, before you get transplanted, you have to have a period of rehabilitation in which you are required to stop drinking.
Yeah,
If you can't stop drinking for 6 months, then you can't be a candidate. Our group discussed this, and they felt if you were alcoholic or addicted to any drug, whether it's alcohol or whatever, and you get a transplant and you lose your organ because of your addiction, that you should not be given the opportunity to get a second transplant. That's what the group decided.
I brought that up because that was the condition my son was in, and the hospitals refused his transplant because of his alcoholism.
Yeah, until they wanted a 6-month period in which you're free of drinking.
Yeah, well, he was kind of far gone. He wouldn't have lasted 6 months. So anyway, but they refused it and he passed.
Yeah.
I just wanted that, since the article was talking about drinking, I just wanted that known that they don't get the same preferences.
No. And although there's been a recent, actually there was a presentation just last week, and they are wondering whether we need to continue to have that 6 months requirement. But I was surprised that our group actually felt that if you had alcoholism as a cause, or any addiction as a cause of failure of the liver, and then after the liver transplant, you went back to it and lost it again, that you shouldn't be given another chance.
Are there any transplant restrictions for obesity?
Yes. If you are over BMI over 40, there are many centers who will not transplant you if your BMI is over 40. And or they'll require you to get your BMI down to 40 or less before they will transplant you. Now, this is an article that I had, I just talked to one of my transplant patients who's 45 years after transplantation. And he's got his booster shot and still has a low antibody titer. And so the question is, should they receive a 4th shot? And most people would say yes, but there haven't been enough studies to give it a real good answer to it. The thinking is that for many, the 3rd dose was not considered a booster, but really just completion of the process. And so the fourth shot, for some, they would think would be the booster. And you can see we're talking about not only organ transplant recipients, but people who are on steroids, people with HIV, and other things. Yeah. And I think Dr. Segan is pointing out that not every immunosuppressed patient is going to require that fourth dose, but some will.
So the need for that extra dose is based on their immunological testing.
Yes. Yes, and even though that is questionable because there's more to preventing COVID than just the antibody, because the cell-mediated immunity is important as well. But yeah, yes, it is based upon antibody testing.
How do they measure that other kind of immunity you were talking about?
Oh, they have a antibody test that measures the amount of neutralizing antibody that is present in your blood. And there are certain levels that they think are necessary to neutralize or kill the virus. And if your level is below that level, then they would think that you need another shot.
That's the regular test that you were talking about. I was talking about the other immune markers.
That's the only test that is done.
Oh, okay.
That's the only test that is done. That's why one of the articles we talked about last week indicated that you're only talking about one component of the immune system, but you got many components of the immune system. So maybe we're being presumptive, and that we don't need to do it because we haven't done any tests to check on the cell-mediated immunity, whether that exists or not. And all we've tested is the antibody portion, but the protection as a result of both the antibody level and the cell T cells or cellular immunity, as well as humoral immunity.
So
humoral means antibody, cellular means the T cells that fight off infection.
So that was my question. Did they have a way to measure the T cell response?
No, we have not incorporated that into the process yet.
Okay.
Well, somebody like Colin Powell, who had multiple myeloma, may not be considered to be fully vaccinated unless they've had like maybe 4 doses. You know, they were saying he was fully vaccinated, but with 2 doses in his immunocompromised condition, that may not have been the case. He may have needed 4 doses.
Correct. That's correct. You're right. You're right, Darryl. Absolutely right. Especially with multiple myeloma being known to produce gamma globulinemia, which means a low antibody titer. So you're right. Even the 4th dose might not have been adequate. So in point of fact, he may not have been fully vaccinated. Well, this is something that we know that the CD panel and most panels expanded the booster rollout for people over 65. Will it be further rolled out? It's a good question. And I think the answer will be provided by what happens with the group that's been given that booster shot and how many breakthroughs will occur after that booster shot. And so time will tell on that one. Now, the mix and match is now something that is recommended. So just about the Pfizer, Moderna, and the J&J are allowed to be mixed so that If you have J&J, you can get Moderna or Pfizer. And that's something that FDA has finally approved as well.
Is that just for the booster, or can you get, say the Pfizer, the first shot Pfizer, the second shot Moderna, or? it's just-
Yeah, and there's evidence that it doesn't matter and that there may be an advantage. So yeah, that's true. You could get your second shot with either. At the time, that was not the case, but now that they've done studies, they recognize mixing and matching is okay. I think that's nice to know because sometimes the J&J and the others felt left out. So now everybody's in. And this explains the fact that over time we recognized we're more knowledgeable now and recognize that mixing and matching works. The
Dr.
period is
Callender,
still 6 months after vaccination.
Dr. Callender, did you hear any I guess feedback from Pfizer and Moderna regarding mixing the vaccines? I guess this interferes with their profit. So was there any discussion from these organizations as to try to prevent the mixing?
Not that I know of, no.
Mm.
I think they would be ill-advised to do that. And probably if they did, it would be kept secret anyway. Because people would say, how greedy can you get? Now, this is the pill that is our future, as we talked about. Tatum talked about our future. I remember it was one of those programs in, I forget the name of the program, but they showed about 50 years into the future, and they had the vaccines in a pill. You take one pill, and that was it. But of course, that's fake. But I can imagine that being the future.
I guess I can too, Dr. Callender, because I sitting here talking to a transplant group, and I can remember very well the first heart transplant. So
Yeah,
my march is on.
yeah, it's amazing how far we've come, huh? And now we have modified an animal to become a source for donors, which may be beginning.
I'm sorry.
of
Dr.
the future.
Callender, are you familiar with the technology of this pill?
No,
How's it different from the mRNA?
no, I'm not.
Okay, maybe we'll do
We'll
some
have to
research
check it out.
on it.
Yeah.
Darryl.
I think as it becomes approved, we'll get the information after the FDA approves it, because they haven't approved it yet.
I knew the guy that had the first, his father had the first mechanical heart. What is his name? Chuck Russell, Charles Russell's dad. You all remember that, Carol and Darryl? You all remember that?
Yeah, I remember Chuck Russell's father. Yes.
He had the first mechanical heart, is that right?
Yes, and his son, Chuck Russell, had no heart at all.
Well, actually, he
Darryl.
died of a heart attack because he was jogging and just fell dead.
His son.
Yeah,
Really?
yeah.
And his father was a judge in Indiana.
Oh,
He was one of our classmates.
oh, really?
Chuck
Mechanical
Russell,
heart
not,
guy, the mechanical heart person was one of
no,
your
he was a
class-
father of one of our classmates.
father one, okay.
Uh-huh.
It's interesting because Israel has a record of having more people vaccinated. They have become the place of first choice to see the effects of vaccines against Delta variants. And so they looked about this in the 12 to 18-year-old group, which is relatively new, and found that it was very effective. In the 12 to 8, of course, now they're going from 5 to 12, but anyway. This is important for the schools because 5 to 12 and 12 to 18 is school-age children. And this is the more recent where the 5 to 12 are now FDA approved. This has caused a lot of controversy. As a parent, are you going to get your child vaccinated?
They're vaccinating them at the schools now. They're going to roll it out. They can get the shot right in school. I think we used to get that, John, when we were in elementary school. We used to get shots or something, some kind of vaccination right in school.
That was a polio in Indiana.
Okay.
Yeah, we used to get that.
It was on a sugar cube, something like that.
I remember that, the sugar cube school.
What do you think parents will feel about it?
Well, since they're more intelligent these days, they'll probably protest.
I think the parents might want to get it done at their family physician instead of at school.
I think wherever, I think they're more likely to want it than not want it.
See, they don't trust the school system for some reason.
Well, the nurses are still healthcare providers.
I think they trust the school system because they surely do send them to school sick and tell them to see the nurse.
Sure do. Sure do. Yeah.
Vaccinated,
Fevers and everything.
vaccinated parents are real happy about this, but people that are vaccine hesitant and reluctant, they don't want their kids vaccinated.
True.
Well, I know in Virginia, they've had to shut some schools down because of the outbreaks and the rate of infection among kids and hospitalization has skyrocketed in some areas. So my wife has been back in the building with children and kids are half wearing a mask. They have to have masks on in DC, but the kids, have them down below their nose or they drop them all the way down. I mean, they're on their chin, and several kids have come down with have tested positive for COVID, and several of them have been on quarantine for 10 days.
Well, that's good reason. That's the good reason for them to want to have the vaccine.
Yeah.
But it's quite interesting to see how it works out.
The dosage is half the dose for an adult, I think.
Well, that's amazing how much progress we've made and how quickly we're able to get these studies done. Well, this is a warning sign to us that what happens other countries may happen here as well. So when you see new infections elsewhere, you wonder whether it's going to happen in the United States as well. So. And this is now almost, this is close to the second year. So I guess in December, it'll be 2 years. Yeah, okay. Lars, get your shot and stay safe. Have a good weekend. Thanks for joining us. We haven't seen much recently on the breakthrough infections, which is something that we were talking about a lot. But it's going to be interesting to see. Look at that. You're looking at what you see. Now, I went to a basketball game last week, and they did the best they could, and they had signs up reminding people to put on their masks. I would say about 80% of the people wore masks. In the now, I'd say about 10% of those people had the mask at the below the nose level, but about most of them wore the mask. They would let you eat at the where you sit, but they'd ask you to wear your mask when you weren't eating. So it's going to be interesting to see how all this works out. At the football games, I guess they don't wear masks at all, huh? Football fans?
When I went, they recommended it, but there was no enforcement of it at all. And I was pretty worried about, we kept ours on the whole time, but a lot of people, and you know, the seats in FedEx are so close, you know, if somebody's sitting next to you and they got it, you got it, you know, unbelievable.
Well, the people in the One Capital Arena, they had pretty signs that said, "Put your mask on." So they tried to monitor it. And if they saw people who weren't, they flashed a sign to them and try to get them to do that, to put the mask on. But they didn't force them to. They just gentle encouragement, which often was ignored. But 80% of the people wore masks. This is interesting. How long the Melbourne, Australia COVID lockdown went on. So they've had lockdowns, lockups, and then lockdowns. And so. And they're talking about inoculations that reach 80 to 90%, which we're far from that. Does anybody haven't seen many recent articles on the ethics of not having world coverage of the vaccinations, and the fact that 95% of Africans in the continent of Africa are not vaccinated. I would have thought there would have been more of an outcry. Any thoughts about that? Or
I haven't heard too much about any other countries lately.
well,
Not
yeah,
even us.
but I was thinking particularly about Africa because
Yeah.
the fact that 95% of the population is not vaccinated, it seemed like that would be a ethical and equitable issue.
Is
for
that
the
one
rest of
of
the
the
world.
countries where we sent the free vaccine, or do you?
Yeah, that's one of the places, but still, only 5% of the population is vaccinated. I think that would be a cause for alarm, or
Well,
should be a cause for alarm.
Yeah, it seems to be racially motivated and wealth inequities. The poorer countries are getting fewer vaccines sent to them. I haven't really compared how many, what's the vaccine supply being given to India compared to Africa. But okay, on the bright side of all this, if there is a bright side, is that even though they're doing less about COVID and HIV on the continent of Africa, Black people do persist. Still, despite COVID and HIV killing Black folks in Africa, we still got the highest Black birth rate in the world of 4. And so like in Europe is 1.6, Africans is 4 despite the deaths, and their population is increasing. And so, yeah,
Yeah,
strong. We do prevail.
that's one way of dealing with it. Yeah, okay. It's interesting for us meat eaters. And you remember the initial infection rate of the meat plants, which was a cause for, that was when Trump was president. And they closed down the meat industry almost. It's interesting how the beef plants, I wonder how many people still eating meat, red meat.
Everybody,
Oh,
Red meat, yeah.
I'm sorry,
Yeah.
Darryl.
Well, it's interesting that there's so much publicity about the danger of red meat, and yet red meat is still so popular.
I have a beef roast cooking downstairs right now.
Oh, when will McDonald's have the plant-based hamburgers?
Do they have them yet?
I know it's been in the newspaper that they're going to get it. I was just wondering
Yeah.
when they're going to produce it.
I might
Well,
eat.
I'm sure when they do, there'll be a lot of publicity. So
I used to love the double cheeseburgers. But I might get a double cheese plant burger though. Try that out.
But it has cheese on it.
Yeah, I like the cheese.
Yeah,
Love
that makes it better.
Cheese does not like you.
I put
what do
cheese.
you think about this article? It's interesting because there's so many things about breastfeeding that are positive.
That was an interesting article. I read it last night, and I don't think there's any truth to that. All right, ladies, help me out.
Well, I think that
So that means we won't get dementia if you breastfeed?
well,
And what if
yeah,
it's-
but the numbers are kind of small.
Oh, okay.
I
2
had
trials with 115 women. That's not much data.
I'm with you, Janice. I don't think that's,
No.
I had 3 children and I didn't breastfeed, and I think I'm doing okay in the knowledge category.
I think it's probably hard to get a sample group, to volunteer for that study.
Yeah, I think if your husband or your man is your breastfeeding surrogate, that would improve brain health.
What?
Oh, boy.
Oh,
Janice, I'm going to wait for more information on that before I can comment on it.
Right, yeah, those
Okay.
numbers too
mhm.
small. Well, I don't know. I'm not sure that this is of value.
Hmm.
Where did they come up with these names? Who named these bacteria and everything?
These bacteriologists and bacteriologists.
Well, they try to figure out how many ways to put letters into position. Who named
I-
that?
Well, the scientists do it. I don't have no idea why they you could probably, they have a good reason. I have no idea. Burkholderia pseudomalia. I mean, wow.
Well, how do you pronounce that anyway?
A lot of them put their own names in it.
Right. Yeah, that's what it looks like it, but I don't know.
Iodiosis.
Well, now, you know what was interesting? Do you know who has the highest vaccination rate in the world?
Who?
China.
I think it's Australia, isn't it?
I was surprised that they said Puerto Rico.
Oh, that's great.
I was very surprised that Puerto Rico had such a high vaccination rate. And when you look at what's going on in Florida and Texas and all those other places.
We'll go back to the top for a second. Look at this.
They have the worst, right? Yeah. It's tough for them to beat out Texas.
That's my birthday right there. October 27th, but not 2021, obviously.
Your birthday was yesterday, John.
That's amazing that Florida has a,
Yes, ma'am.
Happy birthday, belated.
Yeah,
Thank you,
happy
man.
belated birthday, John.
Yeah.
Oh, John spoiled it. I wanted to announce that he had a birthday yesterday, and now he's completed so many years of life, 28 years from his first transplant and 11 years from his third transplant.
Wow.
congratulations.
My son's
Hey,
birthday. Happy birthday.
hey, happy birthday.
Happy
Yes.
birthday, yes, and congratulations.
Thank you.
Yeah, yeah.
Yeah,
That's
my
wonderful.
whole body has a birthday, and my organs have a different birthday.
Wow, that's wonderful.
You celebrate them all.
That's right, each
Yeah.
one of them.
That's right. So, Dr. Callender, when I get to heaven, they're all going to merge, I guess,
Well,
into a spirit.
it's gonna be a spirit. Not,
Yeah, merge into a spirit.
okay.
They announced your
Remember,
birthday, son.
about last month, it was California that was the lowest. Now it's Florida.
Mm. Big states.
I'm waiting for Texas.
Yeah.
We may have to go there by the end of the year.
Yeah, that'd be interesting to see we ever get to that part. Well, it's great to see though, because I remember when Florida was #1, it was frightening.
Yeah, but you know, the other thing about Florida is there's a lot of travel between Florida and Puerto Rico, isn't it? And
Well,
so
it's
they
Florida and
can,
every place else.
yeah,
I mean,
so they can mess people up over in Puerto Rico, bring their
Wow.
numbers down.
Wow. I don't know, that's true.
That's one of the longest lines in the airport from Miami to Puerto Rico.
Yeah, they're taking COVID over there.
Well, you know, the only thing we can hope for is that as we get closer to December, that the drops continue to drop, and that 2022, we will say that COVID is in our past history.
Okay, Dr. Callender, you just said something that I hopefully I could take back to a group that I met with on Zoom yesterday. They were discussing about could they resume normal and how people was going to react to their convention, which is in August, and their board meeting, which is in April. And I sort of thought that everything will have subsided by then in January, because a lot of churches around this area are trying to open up at least by January. They've set that date. So why do people are still thinking that we're going to be in this coronavirus in 2022? Is that a possibility, or they think it's going to go on and on and on?
Well, I was saying that it should be, hopefully it might be over by 2022. That's what I was suggesting. But time will tell. I think most of us are predicting that 2022 would mark the end of the need for most of it. But time will tell.
But okay, besides the vaccine, what else do we need to have?
Just the dropping of the hospitalization and death rates. Continued dropping. And also the increase of people who are vaccinated.
They given up on herd immunity?
Say again?
Have they given up on trying to get to herd immunity before they fully open?
I hope so, because there are many who feel we need to be about 90% to have herd immunity.
It's probably not gonna happen. With the children getting vaccinated, well, that should help herd immunity, though.
I think so. I'm hopeful it will help, because they're a source of the Delta version, which is very transmissible. And this now, can you imagine sending your child to college and have her die like this? Isn't that something? 20-year-old. And how are you going to convince a 20-year-old not to get into a hot dog eating contest? It's amazing. Yeah, well, you know, it's what do you do to somebody who is food stuck in the throat?
Amulet.
I'm
And if that doesn't work, what do you do then?
trick. I don't know.
Hmm? Heimlich is the first thing you do, right?
You hit them in the back real hard.
Yeah, okay, that doesn't work. What do you do?
911.
Well, she had a 4.0 average. Isn't that sad?
They're gonna have to, she's gonna have to have her stomach pumped, I guess.
No. You need to do a tracheostomy.
Yeah, I said a trick. Wanting to.
Well, yeah, you have to do it in time though, but because after 8 minutes, it's too late. So
Mm. But yeah,
Okay.
that means you have to have a doctor present, right?
well, it means you have somebody who knows how to do it. You're right.
And
And you need to have, means you need to have equipment too.
yeah, I was thinking about that.
Yeah. That's-
So, Dr. Callender, I kind of cheated. I have one more article that just came out this morning that maybe
Okay.
we can look at. Here it is. Darryl might.
Oh, yeah. Well, we've talked about the microbiome. I guess that we probably need to start that off next time because
Oh, okay.
it's 10:40.
All righty.
Can the app group meet on next Tuesday at 3:30?
Let's see.
Next Tuesday is election day, Tuesday at 3:30. Can the app group meet? Any takers? Yes for me, yes for Dr. Callender.
Next Tuesday at 3:30,
Yes, ma'am.
that's fine for me.
Janice? Janice still go? Janice.